Thanks for inviting me to discuss, my favorite topic, psoriatic arthritis. So as you know, I'm a professor here in rheumatology in Glasgow, where I've been for about 12 years. And I do both work in the NHS, where I run psoriatic arthritis clinics, and I also do combined dermatology, rheumatology, gastroenterology clinics. And my research in the university is around psoriatic arthritis in general, really trying to understand the disease and make life better for our patients. And we obviously do some rheumatoid and other arthritis research as well.
What are the most underexplored or overlooked areas in psoriatic disease research today?
During my career, there have been so many advances, and we're really lucky with how many treatments we've got. But the thing that strikes me is our patients still don't seem to be doing a lot better. And so for me, the biggest unmet needs are really not new drugs, and we will get new drugs and we need new drugs. But I think that the really interesting research questions from a clinician are, why don't our patients all respond? Can we work out why they don't respond? Can we work out who will and won't respond? Rather than trying a drug and trying another drug, that to me is very unsatisfying. So I think having biomarkers, whatever they are, to really get the right drug to the right patient, understand why people don't respond, maybe prevent some of the difficult to manage PSA that we're seeing. And I think that is a specific group is what's going on in these difficult to manage patients. And I think it's lots of things. And then obviously once we better treatment and that'll improve people's lives and biomarkers of who to treat, when to treat, which drug to treat. I also think there's this aspect of really, can we prevent the disease? So can we intercept patients with existing psoriasis who have already got a condition, so we want to treat them and we need to treat them? Can we intercept PSA developing and actually prevent that? And there's obviously a lot of interest in that. I think those are hard studies, but I think it's really using our drugs to understand the disease better and make, when to use which drugs. For me, it's not another drug, it's which drug is the big question, that I need in clinic. And then there's a few patients who are very difficult to manage disease where I need new drugs and maybe combinations and other things. But for most people, it's just which drug to choose when and can I be better at that?
Metabolic comorbidities such as obesity and insulin resistance are common in PSA. How do you see metabolism influencing disease mechanism and treatment response?
I think that's a big question and a big problem. So we always treat the whole patient. So comorbidities are part of it. And I've always said that in rheumatoid, to me, the cardiovascular comorbidities, the cardiac ischemic heart disease was downstream due to inflammation. So in rheumatoid, we got lucky. We got good drugs, treat inflammation, and the metabolic risks went down and the comorbidities. But to me, in PSA, these conditions are much more part of the disease. Just like inflammatory bowel disease, psoriasis, psoriatic arthritis, uveitis are part of the disease. To me, I think the metabolic component is part of the disease as well. And I think that's in part why we haven't got our patients aren't doing as well as we'd like, because it's not just all our drugs at the moment are just treating inflammation. And that's good for the inflammation bit. But look how many patients are struggling and cardiometabolic problems and especially obesity are the biggest issues. And I think we need to be careful. I think obesity is a marker of something metabolic wrong. I don't think necessarily obesity alone and the weight is the problem. I think what comes with it and what it's telling us about that person and their metabolic state is the problem. And obesity makes every disease worse, but in psoriatic arthritis is part of the disease and psoriasis is part of the disease. So one of your best predictors of getting psoriasis and then getting PSA is obesity. Losing weight reduces that. And we all know that in our clinics, our patients, they don't respond as well to the drugs. And some of that is pharmacodynamics. How much drug do you need? Do you need more? Maybe. But I think some of it is there's a metabolic driver to the disease. And again, we shouldn't be surprised. The immune system is very energy hungry. It's evolved to use energy to quickly respond to pathogens or biomechanical stress or other things. And again, so it's not just the way it senses antigens, our foreign bodies, that we used to in rheumatoid. Our thinking is different. Here, I think part of the problem is the way the immune system uses or has access to or responds to energy. And so I think that we're not going to get PSA better until we address that. And And again, we've seen that, treating PSA and psoriasis doesn't make the obesity go away like it does in rheumatoid. In fact, it's made the impact more. And so I think that, again, highlighting it's part of the disease, not just something that we can ignore. And as rheumatologists, we have ignored it, and now we can't anymore. And we've got opportunities. So I think there's a lot going on there. I think that we need to understand that and hopefully in future have metabolic targeted therapies. But actually, in the short term, I think we can, for the first time, make a difference to weight and hopefully weight loss alone and through some of these GLP-1 drugs, and that will correct some of the underlying metabolic problem or normalize it to the extent that our other drugs work better. But I think that ultimately we will find there'll be specific metabolic abnormalities that we don't know about. And in future, we won't worry about the weight. We will say, well, let's treat that metabolic abnormality. So again, for someone starting out their career in this area, it's one, capturing, recognizing that problem, recognizing the opportunities. We can't answer all of those long-term questions, which metabolites, but we can start understanding what's it doing to disease, how is it impacting the patients, how's it impacting our treatments, and again, a good example is that, obesity is excess weight, but actually it matters whether the weight's in the fat or the muscle or in the liver, and those aren't all the same thing, and we need to understand that to make our patients better. So I think that it's a key bit of it. I think it's the next frontier that we have to cross, and again, I'd rather have good metabolic drugs coming along than another immune modulatory drug on the same pathways we've already got, because I think that's what'll make the difference. And then in future, the question is this instead of, in addition to, before, after, and again, could this help intercept some of the psoriasis and PSA that we've talked about early on?
What advice would you give to early career researchers starting their first PSA project, and especially how to avoid common pitfalls?
I think the key thing to say is that everyone's journey is different. So don't worry if everyone else is on a different path to you. Your journey can be different. And again, I think don't worry about that, but take opportunities. And if you're in a good place, center where there's lots of lab research going on or imaging research, get involved in that, show your enthusiasm, do little projects. But again, if you're less in a high academic center where your opportunities are more limited, think about what are the key clinical questions. What can I do with what I've got here? Can I get some information? Can I get some opportunities? And again, your colleagues and often your patients will tell you what the key questions are. And so, there's big projects, but be happy to start small, go and take opportunities. And again, don't worry if your results, none of our science isn't the breakthrough that we see in the Nobel Prizes. It's lots of little steps. And again, all of those little steps matter and they help and take us forward. So just take those little steps and start from where you are and just take opportunities, but let the patients and the disease guide you to what is it telling me? What is this patient telling me about the disease? What could be going on here? What can I learn? And those are good steps, but really don't worry if your journey looks different to someone who's had a stellar career shooting forward. It's all part of the process, and we need everyone to work together to do research. It's a team sport, that's for sure. Thanks for your time.